I'll be showing a small PPT regarding PIPAC in some time.
Hello, ma'am. It is audible.
Yes.
Yes.
So, Dr. Meena, we are going to start a PIPAC demonstration. Okay. So, I have prepared a few slides, which are very preliminary slides. And there is a caveat. I have just learned about this procedure in my stint at Singapore. So, I thought my residents should be aware of what PIPAC really is. So, we are going to, in the next few slides, understand the basics of PIPAC.
Okay, ma'am.
So, shall we start?
Yes, ma'am.
Okay. So essentially what PIPAC means is pressurized intraperitoneal aerosol chemotherapy. As you can see in this diagrammatic representation, I can't see a cursor. Can we have a cursor here? No, the cursor won't show. But you can see that there is a pressure injector on the right side, okay, in blue, and through which the drug, which is chemotherapy, is injected into the peritoneal cavity after establishment of a normal this CO2 peritoneum, pneumoperitoneum. So the speciality here is that these trocars are not normal trocars. They are balloon trocars, as you can, I'll show you in a while also in the demo. These are small balloons. The function of these balloons is to hold this port tightly without any air leakage, which is of paramount importance in PIPAC. Okay, so this is the inflow tract here. And then we have another 5 mm port where through which we put in a camera port. It's also a balloon trocars, and then there is a closed airway suction outlet which is connected to this trocar. So essentially we require only 2 trocars in this process. Sometimes we may require 3 in case we require to do some peritoneal biopsies. So why PIPAC is necessary? It's quite a recent procedure. It was first introduced in 2011, and human efficacy was first shown by Solas et al. From Germany in 2014. As we all understand, there is some systemic chemotherapy has great limitations beyond a point, and in patients for largely palliative purposes, nothing much is left rather than best supportive care. And perhaps we have some role by using PIPAC in these settings. So there are certain contraindications that we must know before we know about indications. If there is florid extra-abdominal metastasis, the ECOG status is extremely poor, patient is in bowel obstruction, or there is significant intra-abdominal adhesions or disease so that effective pneumoperitoneum is not established, these patients are not candidates for PIPAC. And again, it's the standard that if any patient has any allergy to any of the chemotherapeutic drugs, definitely you cannot go ahead with it. So what are the indications? Indications remain a refractory or recurrent peritoneal metastasis, inoperable disease in a way that PCI is too high for any standard CRS or PIPAC. There is palliation for ascites management. Sometimes PIPAC is being used as a bridge surgery. You do repeated PIPAC and patient becomes a candidate for HIPAC in some time. And definitely when there is multiple chains of chemotherapy have resulted in failure. So what is basic principle governing this? There is a specialized pen. I will be showing you in some time, the Capno pen. This was a prototype. It's a type of nebulizer. There are other companies also manufacturing it. So it causes aerosolization that you can see. This is the pen, that how it looks like, and this is what nebulization actually means. This is how a shower, Swiss snowstorm appearance of the drug that comes out once it's in use. The nozzle tip is very fine. It's only 0.2 millimeters, and the spray cone angle is about 70 degree. The mean droplet size, as you can see, is approximately 25 micrometers. It's extremely small, I beg your pardon. The flow rate can be 0.5 to 0.8 ml per second. That is corresponds to about 30 ml per minute. The injector pressure is very high. So it's the same injector that we use for CT scans, angio injector. And the pressure may rise from 15 to 20 bars as per the requirement and the size of the patient. However, the intra-abdominal capnoperitoneum is standard, that about 12 to 15, again depends upon the size of the patient. So the advantage here is that you are giving high local concentration with very low systemic toxicity. And the other part which is very good is that it can be repeated at least 3 times after 6-week interval. So how we do it, I will show you in the dry demo also, but just a brief. We need to stage the PCI assessment, preferably with an MRI, and do repeated MRIs to assess the disease progression or regression. And in the initial part, we do a diagnostic laparoscopy and find out the PCI surgically. However, the port placement should be minimal. We use generally 2 are advisable, 5 mm for camera and the closed outlet suction, and 12 mm for the Capno pen. And it is advised that every time you go in, you should do at least a 3 or 4 quadrant peritoneal biopsies. These are very small 3 mm, 5 mm biopsies. No adenolysis is permitted because PIPAC can cause, if there is a serosal tear in the intestines while doing adenolysis, there might result in perforation. So all that need not be done. And then we put in this nebulizer or the Capno pen, which should be free floating inside the abdominal cavity with absolutely no bowel contact. And once it is all set, all staff moves out of the OR and aerosol chemo delivery is done either with a remote control injector, or the wire should be such that it can come out of the theater. And as for anesthesia, as Dr. Ray was discussing during his surgery, and that sometimes or most of the times it is only not inhalation but IV anesthesia is used, so that everything can be controlled outside the OR. So essentially it's a closed exposure, and once the procedure is over, one person enters into the OT and stops the CO2 and opens the exhaust valve. So it's a closed suction drain. There is no contamination in the OT atmosphere. And once that is done, the rest of the team enters. Other important point is that all these are disposed of as a chemo disposal system, completely separate of all the things without contamination. The nebulizer generally takes 7 minutes to deliver the drug, depending upon what kind of drug we are using, right? So if there are 2 drugs, they are given one after the other, and thereafter a total time of about 30 minutes is left for the drugs to act in the abdomen. So it's quite a short procedure, so to say. So what are the drug protocols that we use in appendix and colorectal? It's mainly oxaliplatin and mitomycin. If the patient is allergic to oxaliplatin, I'm not sure if mitomycin is available in India. Dr. Neha will tell us. As far as ovarian, gastric, hepatobiliary and mesothelioma, it's a double drug, which is cisplatin and doxorubicin. A word of caution is that these are not yet FDA approved. There are off-label use that we are doing, because PIPAC is still under phase 2 trials in most of the centers. And I think in UP, we are the first center to demonstrate it. It hasn't been used anywhere in UP to the best of our knowledge. So what actually are the outcomes? We are hoping to achieve a peritoneal regression. There is a separate peritoneal regression grading that has been advised, and I'll just go through it in a while. There is good control of ascites. It has a downstaging potential. The best thing about is it's a short procedure with minimal morbidity, right? And it can be sandwiched with systemic chemotherapy in the same sitting. So we don't have to wait for any week or 2 weeks or 3 weeks before we can start systemic chemotherapy immediately after PIPAC. Similarly, bevacizumab is also not a contraindication. Unlike in HIPAC, we have to wait for about 4 to 6 weeks before we start HIPAC in a patient who has been treated with BEV. So as I was telling you, this is the peritoneal regression grading score, and it was again proposed by Solas et al. From Germany. And it scores from 1 to 4. As you can see, it's a pathological grading where 1 is complete response and then 4 is almost no response. And it depends how many tumor cells are left, what is the kind of fibrosis that remains, right? So this is how you, after every time you do a PIPAC, then you see how much the tumor has responded. So safety remains paramount, although this procedure looks very safe overall, but you have to be very careful while using it. It's a closed system. There should not be any contamination of the OT. The OT should preferably have a laminar airflow, HEPA filtration, or a closed, if you don't have that, you have to have a smoke evacuator system so that the exposure to the staff is negligible. Although there have been many studies that even otherwise exposure into the OT atmosphere is minimal, negligible. But over a period of time, it can cause harm, which nobody knows as of now. So it's best not to have any exposure to the best of our ability. So with this, where PIPAC fits in today is perhaps this. In resectable disease with low to moderate PCIs like CRS and HIPEC, we are doing as a curative procedure. For borderline cases which are potentially downstageable, maybe there is a role of PIPAC in the neoadjuvant setting along with systemic chemotherapy. That's a bi-therapy. And if the patient gets sufficiently downstage, they can proceed to CRS with HIPEC. Unresectable disease, of course, there is a definite role in palliative settings. So with this, in some time, I will show you from the theater how the capnopen actually works. Thank you so much for your kind attention. If there are any questions, we can have a discussion. Oh, Dr. Ray is here. Dr. Ray wants to say something.
So regarding the drug, Dr. Mullika mentioned about this for the PIPAC, that oxaliplatin for colorectal and gastric cancer, that is mitomycin and oxaliplatin. Oxaliplatin is the commonly used drug for the PIPAC. Mitomycin, some literature shows they started with the mitomycin, but presently they started in the colorectal and gastric cancer. Only docetaxel, that is 20 milligram, oxaliplatin 90, and that is doxorubicin 4 milligram. That is the fixed dose for the PIPAC at presently we use. And most of the people they are using for the PIPAC. So dose is very important. Usually we remember that 10% of the systemic dose you use in the PIPAC because that goes under the pressure. The chance of bowel perforation is much more higher if you use the more dose. So 10% of the total systemic dose usually we use. And rest of the thing, one important thing to understand, that is a palliative procedure and not like a curative. Even some literature shows those who are using routinely the PIPAC, they are telling the 5 to 14% only there is a chance of complete response, or you can reduce the PCI and you can go for the CRS and HIPEC also. But one important thing being, I see by the Indian scenario, if you see the par setting in the government setting also, the capnopen is costly and 2 lakhs rupees par setting you have to use for the palliative procedure. So it's kind of like, I feel like morally, my moral doesn't support for that. But yes, if they having the affordable patients, those having the suppose insurance is there, then I think you can go for this thing PIPAC. That selective patient you definitely go for this. But regarding the neoadjuvant, I can say the neoadjuvant therapy, there people are using some studies are there, they are using the PIPAC as neoadjuvant. So I don't believe in ovarian cancer and other, where the suppose say initially not resectable disease and you do this as a neoadjuvant setting and 3 times you take the patient to the OT and putting every time 2 lakhs rupees minimum, and then you assess this thing, how much response is there. So that is, I am against that neoadjuvant setting, but palliative setting definitely in selected patient we should go for the PIPAC. So that is a big question, because no company wants that is reused. Even they don't suggest reuse, but truly speaking, I have used 3-4 times and capnopen, and sometimes you have to be ready. But as per their policy, one should use, this is disposable, but I sterilize it and use for the 3 times also maximum. So that is not to be told outside, but you can use for 3 times maximum. So, but the way they make this one, so normally usually it doesn't work in the after second time. So handing over to, right, okay. Any other question you can ask, like regarding PIPAC also? That is true, right.
So as you can see, we are now in the theater. Can you see us? Okay. What is slightly down? Okay, so this is our demo patient, right? And this is the abdomen. So what we need here are two ports, as I was telling. One is a 5 mm port and the other is a 12 mm port. But here we have only normal ports that we use. I will show you how a balloon port actually looks like. And can you focus on this? Just bring it down here. So this is a balloon port. Okay, so you will see how the balloons inflate once we inject some air. So can you see, can you hold the mic for me please? So can you see this? This is a balloon. Yes, exactly. So, and then there is another one here. So what happens is, please follow this here. Deflate it, please.
Yes.
So now, if you can see, this balloon has been deflated. Okay. Now we go inside the abdominal cavity, like that, and then inflate it. नहीं हुआ. Okay. Can you go down? Yeah. So the purpose is that we will pull it out, and this one also sits. So the port is actually sandwiched between, like that. So it is sandwiched between the two balloons. So there is absolutely no chance of trocar dislocation and any aerosol leak. So that is why balloon trocars are very important in a PIPAC procedure. So like we can have it deflated. So normally we use only two ports, as I said, and this one supposedly is our 5 mm port, through which, as you can see, this is a normal laparoscope, okay, telescope, which goes into the abdomen, just like that. You can show, can you show the screen? Screen dikhaiye. Okay. So that's how we do a normal laparoscope. So this is fixed on a book Walter retractor, which they did not keep. So now if I take it out, the other thing that you can see is this is a closed suction drainage. Please show it here, you don't have to show me. So this is the camera port, okay? The camera port is connected with a suction outlet. So this is a closed suction waste disposal. So there should not be any, absolutely no contamination of the OR atmosphere. Do you agree? Yes. And the other thing is then this is the other port. This port has to be a 12 mm port, because this capno pen, this is actually a nebulizer. Can you focus on the pen please? So this is a capno pen. This has a shaft diameter of about 11 to 12 mm, which will not go through a 5 mm port. Please, Gautam, please move aside. So this will go only through this 12 mm port. So generally where to place these ports is also a big question, because generally in advanced cancers, this abdomen has serious adhesions. So generally it is advisable to keep the this capno pen port in the lower quadrant, or whichever, after you establish a pneumoperitoneum and put in a camera port, you have to tailor it accordingly. So generally it is advisable to put it in the lower quadrant. And as you can see, where to put the scope, can you just show inside this? So this port should be freely floating in the abdomen. It should not be touching any bowel. And if you can't take it out, can you just hold it? So it has to be like just coming out. Can you just again please show, focus here, please don't remove your focus. So it should not be like jutting out of your port. It should not be inside the port. It should only be sufficiently outside so that the aerosol comes out. There should not be any clogging here and there, or no touching of bowel in any circumstances. Otherwise, you will have lots of problems in the post-operative period. Okay. So we go again. Can we have this? So as for this capno pen, as you can see, this is connected through a lure lock mechanism into this injector system. Now please focus on the injector system. Can you come there? घुमा दीजिए so that we can see. Just roll it. Please focus on the injector system. We have in most of our CT scan rooms. It's preferable if you are doing a PIPAC procedure, then you should buy it your own. It costs about 4.5 to 5 lakhs. And as, please come. You have to please focus on this. So this is monitored by, can you focus on this? This is a monitor. No, we are not able to see it. So it will show you the flow rate. It will also show you the volume. So the volume or the drug is filled in here. It is pre-filled, as you can see. And everything is all set, and then everybody moves out of the theater. These procedures are not done while being inside the theater. So they have a long connector systems. So generally this monitor is kept outside the theater. Right? So now, please can you start? No, you have to focus it so that we are able to understand what's happening. You have to come here. So as you can see, the syringe, can you just focus on the syringe first? This syringe is already filled. How much is it? So only 50 ml of the drug is there. It's all, in this situation, it's normal saline only. And here, can you just focus here? Focus it more. Can you see it's 50? The volume is here is 50, and we have set a flow rate of 0.4. It can go up to 0.8 also. And then there is pressure also. It's 280 psi, pounds per square inch. Okay? And so that is how everything is set. Now once this is set, here what we have, again please focus. This is a wired connector. Normally we also have a remote injector. So we can actually be outside the theater and then start the injection process. So now, I'm sorry, what's your name? Okay, Mr. Nathan is going to demonstrate how it really works. He is going to push the button, and you can see.
Press this injector, then we can go out, and to start, we'll just push once, this one. Now injector.
So now the system is charging up, and in a while you will see, can you see this? I'm not sure.
We are able to mist is coming out.
Yeah, so it's called a Swiss snowstorm. So this is how the particle size, as I told you, it's 25 micrometer. It's very small. So it goes inside the abdomen. Now they have come up with a modified tip also. It's called the capno tip, which is there is an omega kind of a thing there, and the spray angle becomes 150 degrees. And then there is something called electrostatic PIPAC also, in which they use a charger so that distribution inside the abdomen is very homogeneous. So it's completely soft. But we have to be very sure that there is no OR contamination here. Can we stop this? So what happens is, Dr. Ray, please add as you want. Okay. Can you just, no, don't start it inside. Just move it out. So as you can see, once you have prepped up your patient, the camera port is here. Your telescope is inside the abdomen, which is held in a Book-Walter retractor system. If you have robotic ports, that's fine. If you don't have, you can just use the retractor system that you have. It is very important that these are not moving during the whole procedure. They have to be very static. And then you make sure that all the lure lock systems are working fine. This is the CO2 insufflation. I beg your pardon. This is the exhaust, the outlet, and this is the CO2 insufflation. And once everything is primed up like this, the anesthetist, all the OT team moves out. I repeat, all of them we have to move out of the theater. And then we start the charging system. Now this spray will continue for about 7 minutes. Thereafter, we have to wait for another 30 minutes. So the whole procedure is not more than 45 minutes overall. So once 45 minutes are over, one of the OT staff will enter with full get-up, complete, protection masks and everything, come inside the theater, stop the CO2 insufflation, and open this exhaust valve. So everything gets slowly, in a closed circuit, it gets evacuated. And then the rest of the team enters the theater and does the disposal and removal of the trocars. Dr. Ray wants to say something.
Regarding the port placement, that is very important in case of PIPAC, because normally the first port, that is to around umbilicus 1 centimeter right side to the umbilicus where falciparum is attached, keep the right side, that is for the only the telescope. And another port, normally, usually what happens, you see this thing, even the metastatic disease, particularly the right, the palmar space, that is the left subcostal area, 2 finger breadth below, that area is usually 90 to 95% cases you can put the port there, second port. So that is the thing. Otherwise, suppose always you have to palpate this thing, whether this you feel that no disease is there, then you have to put. So usually the people are putting, even I put in this palmar space, and that is usually 95% case we are able to do. And regarding the drug also, there Dr. Mollika was telling, like you do the oxaliplatin, you have to add in the only 5% dextrose, so that you cannot add with this normal saline. Then you docetaxel and suppose doxorubicin, that you can togetherly you can use with this normal saline, but dextrose to be used for this oxaliplatin. So that is one important thing, and most important thing is that not all palliative procedure you should go for the PIPAC. There is absolute condition if the patient having intestinal obstruction, because there is chance of perforation is almost 100%. So that is very absolute condition. If the patient having the history of obstruction, you should not go for the PIPAC. And another is contraindication is the decompensatory ascites. So when the ascites level is more than 5 liters, you have to take care about that thing. So that is most thing, but adhesion itself does not contraindication for the PIPAC. So if the patient is having the adhesion also, you can go for the PIPAC, but not in the huge ascites more than 6 liter and history of intestinal obstruction. So that is you have to take care. So that is just I added everything she explained properly.
That's a very important point, why dextrose is used for oxaliplatin and normal saline for other drugs, because the drug has to be stable enough in those circumstances. If you mix oxaliplatin with normal saline, there would be problems. And this is the same concept which applies in HIPAC also. So you have to be very sure where you are diluting your drug. Any questions from your end, please? We are most welcome to take.
Sir, it is a sounding aerosol, it is much is present or not?
Again, what is you tell the question?
Dr. Meena, can you repeat your question, please?
It is that all the staff will be out from the hospital.
Yes.
Because the aerosol which is generated might be having a tumor cells. So it is.
So that is true. There is a cytotoxicity, because there is so many literature is there. The cytotoxic diet causes so many problems in the body. Particularly the women, that is called infertility is there, and the toxicity, the abortion history is there, and all the drug toxicity, even in the allergy also. Some people are allergic, even some kind of reaction is also the skin, mucous membrane. So you have to avoid that thing. That's why trocar, that the balloon trocar is to be used. Anyway, you have to protect that. So many toxic effects are there in the body, human body. And because that is under pressure and aerosol is there, that is the more dangerous thing. If you stay with this thing anyway, directly, indirectly, you will be exposed in that. So you have to avoid that.
Yes, and Dr. Meena, there have been several studies which have been published that contamination, if you do a setup like this and are careful, contamination is minimal. But if you are doing repeated PIPACs in lots of patients, there is a possibility of the team getting infected over a period of time, which we definitely want to avoid. As far as aerosolization of tumor particles is concerned, it's not that much of a significance as much as it is for the chemotherapy. Because we have our own immunity which will not, by touching cancer, it doesn't spread like that. So we have our own immunity which will counter that. But chemotherapy definitely over a period of time can have negative effects. We do not have a robust data to back it, but overall, whatever data we have, it says that it's sufficiently safe.
Thank you.
Okay. Anything else for Dr. Ray? Yes.
Ma'am, since simple question. When we all leave the operation theater, how are we supposed to keep the capnopine at a specific distance in the trocar, as you said earlier? Does it have a system, a lock kind of system, that it stays exactly at the tip of the trocar?
That is true. You can see this thing when you see through the telescope, camera, you can see this thing. The total aerosolization is there, and normally we put the omnitract any detector and fix it, so that under the pressure any movement is there, it could be displaced. So that's why we always fixed with this. We put the like any omnitract or Thomson any detector and fix it. So that would be in the proper position.
Okay.
So that usually we do this.
And then see, if you can see, it fits very snugly. So the chances of it sliding down are minimal if you have a proper trocar. New trocars have to be used. And then the thing is that it is a completely disposable setup. You cannot reuse and reuse this, any of it. Think of it as you are doing a transplant procedure, you remove everything away. So it generally doesn't sink down, and as I told you, the tip where you put the tip of the capnopen is very important. It should not be jutting into the abdomen, neither it should be within the shaft of the port. It should be just outside, sufficient to provide a good aerosol without injuring any bowel. That is why if there is lots of adhesions in the abdomen, this PIPAC procedure cannot be done, and it should never be done with an additional lysis. Like if you think that I will do additional lysis and then immediately do PIPAC, it's a big no, because there will be perforations, and it's just not done. Yes, definitely. Otherwise, how will you know how? You will not know whether it is responding to your treatment or not. Yes.
So no, nothing is there. Like this is a kind of drug delivery system, that one has to understand. Nothing is there, no problem is there. You can just start immediately. There is a oral shifts and everything, and we discharge the patient in the same day unless some problem is there. So that is one kind of drug delivery systems, like a chemotherapy. We give the chemotherapy and there is day care system. We discharge the patient after chemo. The same way you can discharge the patient also. That is the good part of the PIPAC.
Yes, and Tarun, we can give systemic chemotherapy the same day. Suppose you admitted the patient, like in Western centers, we do not admit 2-3 days before. You admit the patient in the morning, do PIPAC, take the patient back to the daycare, give systemic chemotherapy, and maybe discharge them tomorrow if they are stable. So it's that safe. So there is a question by our in-house doctor.
After PIPAC, if the patient becomes operable, then can we go for CRS plus HIPAC also in those patients?
So that is his question is there after PIPAC also, whether we can go for the CRS and HIPAC, because that literature says 5 to 14% patient having the good response to the PIPAC. And then the PCI is low, and if the PCI is low, if you just try to do, you can go CRS and HIPAC. Means there is one of the good part of the PIPAC.
So that is a neoadjuvant, as Dr. Ray has said. It's used in neoadjuvant, and but you do not expect dramatic response in most patients. But if the ECOG status is good, PCI is responding, then definitely he or she can become a candidate in. So you can repeat this PIPAC not indefinitely, but at least 3 times, and the interval is about 6 weeks. You need to score PCI on, by that scoring system, pathological as well as repeated MRIs. So don't overdo the case if they are not going on a right trajectory. So be very selective. So it's.
Yeah, because the same port you can take the biopsy only from the different quadrant you can see this, because it's easy to take the biopsy of this. You already telescope is there, and one port you can just take the biopsy. So that's an easier job. That is not a big thing. And what's Gautam, you are asking about this, whether you can use repeatedly. So that's why telling as per the concern that they are not allowing this thing for doing this thing repeatedly, because that is disposable item. But in my practical experience, I have used 2-3 times like this way. Sometimes it works. A single port you can use, like single port surgery, like single port you can use this thing. So no issue with the single port you can use. But usually the double port is better, because sometimes you have to take the biopsy, it would be easier. But theoretically you can use in the single port. No issue there.
Those modified ports where there is a single port and there are two outlets that you can use, but you cannot mix outlet system with capnoperitoneum and all that, so it's not advisable. Everything can be done in an experimental setting, but it's not advisable for everybody. You know, one or two ports will not make a difference, and the biopsies are so small. You don't need, sometimes only rarely will you require a third port. Generally, you can do it in two ports only because they are small. You just nibble, and you do it from all quadrants. The beauty of PIPAC is it will distribute the drugs in areas where others do not reach. All right, and the principle this PIPAC works vis-a-vis HIPAC. In HIPAC, it's passive diffusion of the drug. So the penetration is about 0.1 to 0.2 mm. In PIPAC, it's pressurized chemotherapy, so it's convection plus passive diffusion. So the distribution and the penetration of the drug is 0.5 to 0.8 mm. So it also works in advanced disease where there are tumor nodules, right?
If I may ask, what's the indication of biopsy before we go to the because most of the patients would have got systemic chemotherapy, would have got biopsy.
Again, the question.
Why we need to do the biopsy?
So biopsy, because you see how much regression is there, how much response, because this is he told already, the penetration of this drug is much more higher than this HIPAC. So normal chemotherapy cannot penetrate inside because of the plasma peritoneal barrier. That's why the systemic drug is not the concept of the intraperitoneal chemotherapy because of this only. Because the systemic does penetration to the abdominal cavity is lack because of the plasma peritoneal barrier. So here in compared to the HIPAC, the much more penetration is there because of aerosolization and under the pressure. So that's why you have to see how much penetration is there, how much response is there, because we expect the response will be better in PIPAC. That's why you see the regression score.
That is why, Tarun, it's not only biopsy, you also need MRI. So to be sure where you are heading. And yeah. And as you can see, this is a simple, regularly that we use grasper. You can take biopsies from any quadrant. That should not be a problem. You don't need to dissect and take a very deep biopsy. Okay, thank you. So there is one more thing that I would like to show you guys today. Can we focus on this laptop presentation? No, let us just have it focused first. So that is something like after a low colorectal anastomosis, we do an ileostomy. Now we have something that we can avoid doing an ileostomy and just do this. So this way we will be able to avoid another surgery for the patient. As you can see, this is a silicone catheter and it has been introduced inside the abdomen through the cecum. And it goes into the terminal ileum for a distance. And then there is a flange there that fixes this. Can you show this also? So can you hold this for me, please? Can you just pause this? So can you focus on this catheter? So that is the catheter, all right? And this is the flange. So you introduce, and there is an introducer. So it's just like a Foley's catheter, and then we have this introducer. Which way it goes? This way only? So it becomes rigid. So we put it inside through the cecum. It goes into the terminal ileum, howsoever long it needs to go. And once you have adjusted, then we inflate the balloon, just like a Foley's catheter. Please focus here. Please focus here. See, can you see this balloon has been inflated? Can you deflate it, please? Suck it out. See, it gets deflated. So while introducing, it is in a deflated state, and once it is positioned appropriately, inflate it again. Keep the focus. So there you go. And then you can retract it sufficiently when it is safe enough. Can you focus on this flange? This flange you're not showing. Yes. So this sticks onto the abdominal wall. And then it stays there for 2-3 weeks, howsoever you want. And thereafter, it is simply deflated and the thing is removed. The patient doesn't need any ileostomy surgery, so as to ileostomy closure procedure. You can as well watch this video once again. What happened? Can you focus on this? Can you play it? Just play it.
Ma'am, what is this instrument called?
Alpitube, ma'am. It is called LP tube, and it is from EFG Medical, Rome, Italy. Yeah, just we got registration, everything done, ma'am. Hereafter, it will be available in India.
So there are big holes on the sides, multiple holes, so it will drain out the contents. And it's it's newly available. I don't think we have a rate as yet. It has just been launched and CE certified, ma'am. So I think the company person will get in touch with you. It's not going to be very cheap, but still it will save us from another surgery and the patient also from undergoing the morbidity of ileostomy closure and the ileostomy complications that we see so often. Thank you. Yeah, I mean, it's hard to say as of now. We don't have any robust data on it. Anything you want to add? Okay. Thank you.